Could FDA-approved Vyvgart, efgartigimod alpha FCAB for intravenous infusion, or Vyvgart Hytrulo, efgartigimod alpha and hyaluronidase QVFC for subcutaneous injection help your adult patients? Explore clinical trial data and learn how to get patients started at VyvgartHCP.com. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi there, it's Vikram Karnik with the University of Calgary and the Neurology podcast. On this week's featured article interview podcast, I'm speaking with Rob DeBee. Rob is a movement disorders neurologist and professor of neurology at Amsterdam University Medical Center, and author of an article published in Movement Disorders titled Long-Term Follow-Up of the LEAP Study, Early versus Delayed Levodopa in Early Parkinson's Disease. In this study, Rob and his collaborators conducted long-term follow-up on patients enrolled in the original LEAP study and looked at the long-term effects of early versus later onset initiation of levodopa in Parkinson's disease. Rob, welcome to the podcast and thanks for joining us.
Thanks for having me on the podcast.
Before we get into the details of the study, I'm hoping to hear your big picture take-home message that our listeners can apply to their clinical practice. What do we learn about these two different groups that people can apply day to day?
The main message is basically that levodopa does not have an effect on the long-term course of Parkinson's disease. You can take levodopa to suppress bothersome symptoms as needed, and you can start levodopa in case of minimal disability. That being said, you shouldn't unnecessarily use too much. You can adjust the dosage based on symptom severity and don't need to be afraid of possible negative long-term effects.
You know, we use levodopa very commonly in our clinics. I'm wondering if maybe you could tell us what led to the original LEAP study being done. Why was that study necessary? And why did we need this long-term follow-up?
So in the past, there was fear of toxicity of levodopa and side effects in the long term like dyskinesia. And the idea was that early start with levodopa would increase these side effects later on. So what we did in the original study, people with early Parkinson's disease who had not yet used any medication were randomly assigned to either 80 weeks of levodopa 3 times a day, 100 milligrams, or to first receive 40 weeks of levodopa, followed by 40 weeks of levodopa 3 times a day, 100 milligrams. So by the end, all patients had used levodopa for 40 weeks. And if there was any difference between the two groups at 80 weeks, this would be due to the different treatments during the first 40 weeks, with any effect persisting for the subsequent 40 weeks. Ultimately, at 80 weeks, we found no difference between the participants who started with levodopa early and those who started 40 weeks later, strongly suggesting that the levodopa doesn't have a disease-modifying effect. Some found the follow-up duration short, which is why we chose for the longer follow-up, also because certain symptoms become more clearer over time.
Yeah, that's terrific. Thanks for that. Now we can get into the data of this study a little bit. This longer-term follow-up, as you said, was requested because people felt the original follow-up was a little bit short. What did we see between the two groups at this longer-term follow-up at 3 or 5 years? How did the two groups differ?
So at the end of the initial study at 80 weeks, it seemed like the early starters had slightly fewer mild response fluctuations, but there was no other difference between the two groups. 5 years, early starters seemed to have slightly worse Parkinson's symptoms, but they also had slightly fewer dyskinesias. And none of these findings were statistically significant. And more importantly, these findings contradict each other. If it were a result of more severe disease progression, one would expect that the group with more severe Parkinsonism would also have more severe dyskinesia. What we found goes against this expectation and seems more in line with some minor random fluctuations. So even after 5 years, there's no difference between the two groups.
And how did this differ from other studies looking at early initiation of levodopa versus potential other levodopa-sparing therapies such as agonists or enzyme inhibitors?
In most older studies where levodopa-sparing treatments were compared with levodopa, the focus was on side effects. So these studies showed that starting with, for example, a dopamine agonist resulted in fewer dyskinesia than with levodopa. But if you delve into those studies, you'll see that this comes at the expense of less reduction in Parkinsonism with the agonist compared to levodopa. So those studies also showed that all patients starting with a dopamine agonist eventually needed levodopa. I think it's also important to realize that our study is different in the sense that the controlled phase, part where levodopa is compared to placebo, is relatively short compared to the older studies where levodopa-sparing strategies are investigated.
Right. One point that was kind of brought up in the study was that your group didn't distinguish between on and off states when rating the UPDRS in this population when people were assessed for follow-up. Do you think this affected the data at all?
Indeed, when we assessed the participants using the UPDRS scale, which is a scale to measure severity of Parkinson's symptoms, we did not take into account the timing of levodopa intake. This was because our budget did not allow for standardized moments for the measurements, such as 12 hours after the last levodopa intake, and also participants were relatively early in the disease, and we didn't expect clear motor fluctuations yet, meaning a large proportion of patients wouldn't experience off periods 12 hours after the intake of medication. The downside here is that the levodopa use might have masked a potential difference in disease progression, even if there are no fluctuations yet. In another analysis of the LEAP study, we observed that levodopa provides both immediate symptomatic improvement and, over a longer period, an additional improvement known as the long duration response. So even if we had measured the UPDRS 12 hours after the last levodopa intake, the findings might still have been affected by this long duration symptomatic effect. If 5 years after inclusion in the study, there is still no difference between the two groups, it's reassuring in terms of levodopa not having a long-term effect or disease-modifying effect.
Right. And this is the inherent challenge of disease modification studies in Parkinson's disease. It's the timing of the assessment, I think. And it's something that we still struggle with a little bit. But thanks for that response. Do you think a more heavily powered study maybe would have resulted in any statistical differences? You mentioned a few earlier where there were maybe some slight differences that were not significant. Do you think a more heavily powered study would have changed things at all?
To be honest, if we had the budget, we would have evaluated patients in both the off and the on phase at 5 years. I think that would add more value than including more patients.
Budget limiting, the study still showed us that early versus delayed initiation of levodopa went along with what we thought in the past, and that there were probably going to be no significant differences, and that's what your group showed. But one interesting other point that you mentioned in your paper is with this long-term follow-up, we could actually evaluate successful rates of diagnosis of idiopathic Parkinson's disease. I know sometimes at the clinic when it's early, we're not clear whether we're dealing with Parkinson's disease or an atypical Parkinsonism or perhaps something else. And with this long-term follow-up, we could actually evaluate that. So at 5 years, how many patients were confirmed to have a diagnosis of idiopathic PD? And how did this compare to prior data seen in the literature for neurologists or movement disorder specialists?
Only 6% of the patients in the original study didn't actually have Parkinson's disease, but another diagnosis 5 years after the study started. This percentage is lower compared to other studies that recruited patients with early PD. It's about 10 to 15% normally. One possible reason for this high accuracy in clinical diagnosis could be that neurologists didn't refer patients for the trial if they weren't very confident about the diagnosis. Supporting this explanation is the relatively large number of 104 patients who had a dopamine transporter SPECT scan before being referred for the trial. This likely helped to exclude individuals with conditions like essential tremor or dystonic tremor, which were rare in this study. Out of the 27 patients who didn't have Parkinson's, 13 had multiple system atrophy and 5 had progressive supranuclear palsy. This aligns with the findings of a comprehensive meta-analysis, which also identified multiple system atrophy as the most commonly misdiagnosed disease for Parkinson's, with progressive supranuclear palsy being the second most common misdiagnosis. This meta-analysis also highlighted dementia with Lewy bodies and Alzheimer's disease are frequently misdiagnosed as Parkinson's. But these conditions weren't among the misdiagnosed diseases in our study group because dementia was an exclusion criterion.
Terrific. So 94% success rate in diagnosing Parkinson's undoubtedly strengthened the data. So that's great. In the past, we've had debates around various dopaminergic medications. What comes to mind is rasagiline in the past as being potentially disease-modifying, which has since been disproven. Is this finally the end of the debate around dopaminergic medications being disease-modifying, or do you think there's room for further investigation in these agents?
I'd like to remain humble. I don't know what the future holds, but I believe that if there is any effect from the dopaminergic medication beyond immediate symptomatic and long-duration symptomatic effects, it probably won't be very significant, let's say negligible.
We like to come back to how studies like this may have changed your clinical practice. So I'm wondering how this study changed your approach to managing patients with Parkinson's disease. Are there any patients now where levodopa would not be your first choice treatment option for motor symptoms? How are you practicing now based on the results of this study?
So when it comes to starting medication, I actually advise every patient to begin with levodopa. With this study, I dare to say with even more confidence that's been demonstrated that levodopa doesn't influence disease progression. I find it more convincing to say that's been proven that levodopa doesn't accelerate disease progression than to say it hasn't been shown that it does. For young women, people who aren't very overweight, if there are early signs of response fluctuation, I might add a dopamine agonist a bit sooner. For young men, I avoid the agonists.
Once again, I've been speaking with Rob de Bie, a movement disorders neurologist and professor of neurology at Amsterdam University Medical Center, about his group's paper titled Long-Term Follow-Up of the LEAP Study, Early versus Delayed Levodopa in Early Parkinson's Disease. Please check out the paper recently published on April 21st in Movement Disorders, and have a great week.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.